Welcome everybody to this session, this plenary, and title is Learning from the Hard Reality of Trying to Create Integrated Care, Reflections from Research and Implementation. Let me explain how we came up with this session. So we had two workshops submitted to the conference, and then one was more on research and evidence of what was going on in the United Kingdom. And then there was this other one which was more experiential, was looking at the experience of people trying integrated care for a while, and then how they were, so the thinking was, if I had known 10, 15 years ago when I started, it's not that I wouldn't have tried, but I would have done things differently, no? Or I wish I had learned where I started. And then the scientific committee challenged us to do this combined workshop, and they said, we're going to put you in the auditorium, and this is going to be live stream. I would say fantastic, but the challenge was how to actually, if you remember, the title of this first plenary, From Evidence to Policy, and from policy to practice. So this sub-plenary actually is trying to do that jump from evidence to policy, from policy to practice. And if you remember the sub-plenary, there are two words missing, politics and then back to evidence. So we are going to do something which we hope you find interesting. Let me explain that how it is going to be structured. 3 parts. Part A, we are going to start with the research. So the Nuffield Trust, our colleagues from the Nuffield Trust are going to present the research on the UK. Then we are going to move to part B, experiential, and we've got representatives from Catalonia, the Basque Country and Wales. And then part C is you. Part C is the audience. We are going to engage through Menti, which we'll explain later. And we are going to be voting and discussing, and then we are going to have this conversation with a panel and with you about, now we are starting the journey. Probably some of you have just started your journey on integrated care. Some of you have been going on this for a while, and that's what we are going to discuss. I've explained this, and now this is my request, that people there, if you want to move back, if you don't want to move, that's fine. So we can be closer, and then when it comes to voting, it's going to be more fun. And then also we are going to have microphones. So that's the idea. People up there, if you guys want to move up here, it will be much appreciated. If you want to stay where you are, fine. But it's just that it's easier then to engage in the conversation. And I'm going to stop here and give the word to my colleagues from the Nuffield Trust. And then we are going to start this part A on the research and the evidence. What does the evidence tell us about the integrated care and the challenges and the opportunities of integrated care? So you introduce yourself, and please, the floor is yours.
Thank you, Arturo. So Camille and I are joining you today from the Nuffield Trust, which is a charitable think tank in London which studies health and social care across the UK. And what we're presenting comes from research that we did about 3 or 4 years ago, trying to learn some lessons from the progress of integrated care across the UK. And we reflected that over a period of 20 years, since around the turn of the millennium, when health had been devolved to Scotland, Wales and Northern Ireland, and particularly since 2013, each of the countries had come to have major national policy drives to create better integrated care across health and social care. So we aimed to compare across their initiatives, to look at the levers that they used, and as far as we could, to look at the success that they'd had, and what we could learn from that, particularly now, as each of those countries moves into a new period of further initiatives to try to achieve integrated care. So I'm going to begin by giving a quick overview of how health and social care are structured in each of the UK's countries, and what this means for both the position going into integrated care as a policy aim, and some of the structural changes created as a result of that. So we see, first of all, a comparison of the 4 countries in their spending on health and social care. And important points to note here are that spending per person on health is currently reasonably similar in each country, but somewhat higher in Northern Ireland and Wales than in England and Scotland. And that possibly reflects political choices and funding patterns, but also that Northern Ireland and Wales, for different reasons, have particularly high healthcare needs. You can see that the spending on healthcare as a share of total spending on public services is quite similar between the different countries. The same is not true for social care. Spending on social care is very different between the countries. Northern Ireland spends far more than the other countries. England spends less. And spending on social care as a share of total spending varies as well. Now that tells you that while the UK generally shares a modelled funding healthcare, paid for by taxation, largely free at the point of use, although England charges for prescription, the offer for long-term care and support is very different in these countries. Each country does have a model where there is a means test. You don't get publicly funded social care unless your assets, your pension, often housing, fall below a certain level. But these vary between them. Wales has a more generous threshold. People start receiving funding sooner. Scotland also a somewhat higher one. And for each of these, you'll have to be eligible in terms of your needs for care to be allowed to receive state-funded support. So in general, a much less comprehensive system. But the countries differ not only in the thresholds, but in the additional support they offer. England doesn't offer any additional support, but the other countries have added guarantees of free or accessible care for people. A cap on non-residential care in Wales, and that's free in Northern Ireland. And Scotland offers free personal care and free nursing care. So while that doesn't cover all social care, it's a meaningfully more generous system. We'll next go through the countries just very quickly. Don't worry, I don't expect you to remember all of these very complicated diagrams. England in particular likes to have a nice complicated organisation chart. But it's worth noting that you'll see here the separation of health and social care going up. Healthcare on the left side as you see it, funded by taxes through NHS England. Social care to your right, funded through the Department for Housing and Communities. Social care is held by local authorities who are also responsible for housing and transport. The NHS is a national system. You can see that England has integrated care systems, which councils sit on, but they're fundamentally primarily overseeing the health sector. And England has separate providers who compete with one another called NHS trusts, who actually deliver secondary care across mental and physical health. If we look at Wales, we see a simpler structure. There's the same divide between social care held primarily by local authorities, but health is both delivered and planned for by health boards, which cover different areas of the country, and services such as ambulances. And both are accountable more closely to the Welsh Government at the centre. You'll see the regional partnership boards connect the social care holding and healthcare holding services, but they don't themselves directly receive the budget for care. Scotland has a similar makeup with territorial NHS boards, social care held by local authorities. It has integration authorities which connect the local authorities and the NHS boards, and they do hold budgets and direct the procurement of services from the other two, although a strong proportion of the responsibility for planning, funding and running services still rests on the two sides, separated off. And lastly, Northern Ireland. Northern Ireland is different to the other countries in that it's had structurally integrated health and social care since the 1970s. Both are held by health and social care trusts, which cover 5 different areas of the region. Around those, there have been a sequence of initiatives to try to provide more integrated care, even within a context where the same provider holds health and social care. You can see here a partially reformed system, and I know you've heard a bit this week about further changes being made, with integrated care partnerships assisting in that process. So to summarise, before I pass to Camille to talk in more depth about why and how the reforms that created some of those integration bodies came about, key similarities and differences. All the countries have a nationally funded health service which is largely free at the point of use, paid for by national taxation, which is largely at a UK level. All the countries have a much less comprehensive publicly funded social care offer. Northern Ireland is unique in that health and social care are structurally united, but everywhere else, social care is run by local authorities and health is run from central government. And England is unique in that it has autonomous providers, an attempt to have a competitive market inside its state-run healthcare system, with purchasers who are separate from the bodies delivering care. And I think the last important context to bear in mind is that all countries are currently experiencing very serious problems with waiting times and financial control, particularly following COVID-19. So I'm now going to hand over to Camille Ung, who is a fellow at the Nuffield Trust specialising in social care, to describe how we understood the large number of reform initiatives to create better integrated care across these countries.
Thanks, Mark. And sorry, we're doing a bit of a hokey-cokey between ourselves and the podium. The clicker. Thank you very much. Yes, so part of the work that we did was looking across the policy initiatives that were developed across the UK, policymakers in the last 20 years, so since devolution, to really learn from this natural experiment of the 4 UK countries having similar but slightly different approaches, slightly different health and care systems. So the main of our study goes up to goes up to 2021, but there have been some changes and tweaks since then. We've discussed some of them across the conference. So we've talked a little bit about the changes going on across Northern Ireland, and we'll hear more from Wales shortly. But I think what's really key here is that there were almost 70 major initiatives developed across the UK in the last 20 years, which really highlights how much of a big and consistent focused integration has been across the UK. A lot of these initiatives have overlapped, so we won't be talking to all of them today, such as the vanguards and pioneers in England that were about 10 years ago. But I think it makes it very difficult to outline some of the, or discern some of the impacts that each of these overlapping, consistent initiatives has had over the last 20 years. And although the 4 countries have implemented integration policies that are different at different times and to different extents, they've really shared some broadly shared ambitions, some broadly shared aims. So we've broken these down into kind of 3 main buckets, and again, we've heard a lot of this across the last 2 days of the conference. So firstly, improved experience, so for patients, for people drawing on care, as well as improved quality. Efficiency across the system, so a better use of resources, reduced dependency on the acute sector, cost savings, those sorts of things. And then finally, the big one around population outcomes, such as prevention, reduced inequalities, and improved population health. And I think it's fair to say there's been some really big buy-in for some of these big integrated care reforms. We heard yesterday from Rafa Bengoa about the Northern Ireland approach and how much of that buy-in has really been supported across the health and care sector. And that's really set a tone for really strengthening the integrated approach across the UK. It's also worth noting for context, I think, that there's been general population health improvements across the UK in the last 20 years, really irrespective of integration policy. And so it's kind of been hard to tell how much of those improvements have been linked to wider population health measures rather than integration of itself. So what we found in our policy analysis of the kind of 4 UK countries is that all of the countries have drawn on 4 main national levers to drive integration across their 20 years of initiatives. So structural reorganisation is probably the most common one, so where policymakers have sought to bring together different partners under joint governance structures, and increasingly in the UK these have had a statutory status and a greater share of responsibility. Integrated finances have also been a main feature, so for instance by pooling or by aligning budgets. So for instance in England under the Better Care Fund we've had some quite major integrated finance arrangements. And then we've also had things like transformational funding, so not consistently but to invest upfront into measures to support the integration process, so multidisciplinary teams, integrated commissioning, those sorts of things. And then finally through performance management, so setting measures or targets for the system to move towards and assess any improvements. So before I hand over back to Mark again, just a quick summary slide of how this plays out currently across the 4 UK countries. So all of the 4 countries have some form of joint governance arrangement, although they do cover different sizes of populations. So, of course, in England, integrated systems cover up to 1 to 2 million people, so it's much larger than some of the other structures. And of course, as Mark mentioned, we have health and social care trusts in Northern Ireland that are fully integrated. And the other countries operate on a more of a membership basis, and there's varying degrees of statutory membership as part of that. Likewise, across the 4 countries, there are varying degrees of financial integration, with greater efforts to bring finances together and move resources out of hospital and into the community. And some have been mostly focused around certain issues, such as discharge from hospital, so the Better Care Fund in England, while others have had a broader remit around community care, such as in Scotland. Performance management has been much more limited in England compared to the other countries who relied on more national performance frameworks or programmes for government which have really set that tone. So I'll hand over back to Mark now, who will take you through some of the performance measures that we've looked at, that we were able to compare across the 4 countries of the UK to see whether we could see any impact of these integrated care initiatives.
Thanks, Cami. So yes, in order to look at whether these integrated care initiatives had achieved their aims, we went through a process of starting from the 70 initiatives that Cami mentioned, based on the full-up typology from 2005. We analysed them for themes and objectives, used that to make a long list of measures which were accurate measures of whether that they'd achieved those goals. And then, of course, had to winnow it down quite a lot to only those which could be compared across the UK countries. And the UK countries tend to use different data sources and methodologies. So we ended up with a relatively small number of measures, but fortunately it does cover many of the key dimensions through which integrated care would be expected to make a positive difference to people's health. In total, we looked across 10 measures. I'm not going to go through them all, but they were mortality, treatable mortality, emergency admissions, length of stay and delayed transfers from people leaving hospital, satisfaction with social care, access to employment for people with long-term health conditions, and inequalities in healthy life expectancy, reflecting desire for greater equity in many of these policies. So I'm going to look at 5 here, which we've updated recently to the sort of post-COVID era. But our conclusions very much are based across that wider list. So if we start with emergency admissions, this was a really important one for many of the different initiatives in the different countries, an important part of Scotland's core suite of integration indicators, explicit goal for the different models of both provider and funding integration that we saw in England around 2015. We see little discernible trend during the period of and succeeding that sort of first wave of national integration indicators across England, Scotland and Wales shown here. So England shows essentially no trend in age standardised emergency admissions per 100,000. Scotland and Wales see, if anything, a gradual increase rather than decline. And then at the end of the period, we see the effect of COVID-19 with a sharp decrease in emergency admissions. We believe that's primarily driven by patient behaviour and capacity constraints, as you'll see a bit later in some of the other indicators, swamping any obvious effect of that we might expect to be associated with national policy. Hospital length of stay emerges a consistent theme as well, and of course indicates to some extent whether a system can find safe, reliable capacity in the community and in social care to discharge people from hospital. Again, we broadly see little change over the sort of 7 years before the pandemic. There's a slight improvement in Wales, Scotland and England, but that's reversed when COVID-19 hits quite meaningfully. And this, I should say, actually reverses to some extent or slows an earlier trend. Before 2013, length of stay had fallen quite fast in all of the countries. So to some extent, this was a period of stagnating progress, interrupted then, sadly, by COVID-19. We saw much more meaningfully positive signs in the trend of people with a long-term condition who were able to find employment. All the countries saw an improvement up to 2019-20, quite similar across them, although you'll note the lower rates in Northern Ireland, reflecting a range of population health issues. We then see that, of course, reversed during COVID, but there is a recovery. So this is a relatively positive trend. It's important, of course, to associate this with changes in the labour market as well as within health, social care, public health. The middle of the decade was a period of high employment and low unemployment across the UK, a period of flat wages but a very tight labour market. And of course that changed as COVID-19 hit and caused economic disruption. If we look now at treatable mortality, we again see that the period from around 2012 or 2013 in fact represented something of a pause in progress. And of course there are many other factors going on here. You saw a period of lower spending by some public services, and some of the rapid improvements that in particular Northern Ireland had made as it recovered from conflict might have been expected to stop at some stage. But you certainly don't see a reduction in mortality that should have been amenable to treatment in healthcare. And again, as with length of stay, we do see that this was a period when a previous trend of things getting better appeared to level off. The last indicator that I'd like to share, because I think it sums up something quite important about maybe some of what underpins the patterns that we saw during this period, is the balance of spend. So there was often an explicit hope that social care and health integration would lead to a gradual rebalancing of spend away from healthcare, or at least hospital care, and into social care, which, as we've seen, is a service where particularly some UK countries spent really quite low amounts on. In general, that's not what we see, though. In England, social care spending as a proportion of services spending has actually fallen, and in fact it fell in real terms for much of this period. It actually went down per person, while health spending rose strongly. And we see the same pattern, less pronounced, but the same pattern in Wales. In Scotland, we see a similar growth in social care and in healthcare, implying no rebalancing, but more or less a continuation. Northern Ireland is the one exception. It does see social care rising more rapidly than health. There is maybe a bit of a caveat around that data, because it is a system where those two are structurally integrated, so there's more of a scope for possibly definitional changes. But it does seem that there should have been a redistribution from health to social care. So across these indicators overall, what we see are trends driven by a wide number of things, certainly population, economy, changes in public health, but certainly no dramatic pattern of improvement or change on the indicators we looked at. And the same broadly goes for the other indicators we looked at in our wider study. So I'm now going to hand back to Camille, who will discuss some of the lessons that we took from this exercise.
Thanks, Mark. So before I hand back to Arturo and to move us on to part B, just wanted to summarise kind of 5 broad lessons from our work that we will be really interested to hear from in terms of the panel's own experience and their expertise of doing this in their own countries. So from the perspective of the UK, I think a lot of the integration policy has been set by national level policymakers with some very top-down levers to support integration. So things like pooled budgets or structural reorganisations such as that of the ICS recently in England, transformational funding, etc. And I think while these can help deliver some improvements to joined-up services at a local level, the theory of change, perhaps, of how these levers on their own will lead to the improvements that integration is intended to achieve at a local level, such as improving population outcomes, creating efficiencies, that theory of change isn't exactly clear. So I think there's been an assumption that structural changes will naturally overcome existing barriers, but as we've heard a lot about the importance of culture and relationships, it's really important to make sure that those are kind of taken into the equation to overcome some of these existing kind of cultural barriers. I think one of the big challenges in England, Wales and Scotland perhaps is the different accountabilities between the NHS and social care, with local authorities being accountable to their local electorate, and having to balance their budget every year. So the context in which these different integrating partners are very different, and the structures on their own haven't perhaps been sufficient to address this. And so there's lots of on-the-ground things to discover and overcome that I think national levers can enable, but maybe not sufficient to overcome. Acute hospital trusts have really dominated still, and it's been difficult to shift funding flows, especially in the context of high demand. And this has really potentially limited some of the benefits of integration initiatives, although there has been some success around things like discharge pathways. And I think it's interesting that countries such as Scotland have been considering changing their integrated structures to reintegrate around community health and social care and remove acute from the equation. But the delays kind of really highlight how difficult it is to make some of these difficult trade-offs and decisions. And as we've seen from the indicators that Mark outlined, it's very difficult to see any immediate big change or impact directly linked to those initiatives, at least in the measures that we've been looking at. And I think it's been very difficult for us as researchers to measure integrated care. So things like footprints have changed, the outcomes might not have the right data and might be difficult to quantify. The data might not exist. You can't exclude other confounders. And in many cases, there's also this interesting phenomenon that integration might lead to some improvement. So for instance, identifying unmet need, but that might then not lead to cost efficiencies because you're picking up people who otherwise wouldn't have been picked up by the system. So it's really hard to see really what the impact of what's going on. And so our kind of takeaway was that it was really important to have realistic objectives around what integration can achieve. And the evidence base to date, I think, suggests that integration at a national level can have a greater potential for, impact on patient and person experience. But cost efficiencies, I think, needs to still be demonstrated, at least to be able to look at it from a national level. So we need to be careful not to measure the wrong thing. But yeah, some interesting challenges, I think, that will be good to hear from about the panel. Thank you.
Thank you very much. Very interesting. We've got questions coming in from Q&A. Thanks very much. And we've got 2 minutes before we move to part B. And actually, I was thinking, I don't know, last slide, if we can put it back. No, we're changing, no worries. Because if you retain that slide, guys, that's something that I might want to come back to that. To you, because those things that we had there is probably what we are going to reflect now. But is there any burning question that we've got in from the audience right now? Neus, if you, just in case we've got. Anybody, please? There's somebody there, so we can take a couple of questions before we move to part B. So yes, thank you. There was this lady here as well. No, that's fine, no worries.
Good afternoon. I'm Mike Emery from Wales. I suppose it's just a reflection. I was sort of interested in the study around. So, did anything come out about that power imbalance then when we look at integration between acutes and community side of things? Do we think that we're likely to be more successful if we take acute and secondary care out of the whole policy space? I've worked in both the English and Welsh systems, and it's fascinating to me, despite bringing together integration into one structure, we still end up focusing very hard on that acute centre. Just an observation part question.
Yeah, that's a very interesting observation. I think thinking back to this period, it is interesting to reflect one of the reasons that acute care did tend to be part of all of these, and that was really that there was a hope that integrated care on this model could deliver savings to acute care, and they could be cycled out into community care and into social care, and so that you would sort of almost redistribute funding with the consent, if you like, of the acute sector, with direct benefits coming to it. And I think that's proven to be quite challenging. And many of the metrics that we looked at, which reflected the emphasis that we got from those policy documents, were particularly ones in exactly that area of, is it actually cutting your number of emergency admissions? Is it reducing your bed days? And so, yeah, perhaps the logic for including acute care on the grounds that it's where the money is weaker if it isn't being freed up in that way. At the same time, obviously, reality does remain that it is where the money is. And so leaving it out, in a sense, just passes on the quite difficult task of who decides where to prioritize resources.
Very good. I think I saw a hand here, this lady. Thank you.
Thank you for that. I know you have a limited amount of time, of course, for the presentation. I'm assuming you did measure satisfaction with social care. It was one of your few indicators from an individual perspective, from a more micro sense. Do you want to tell us a bit about that? About the levels of satisfaction? If you can.
Yes, so we have, in fact, we can point you to our report afterwards, which has that graph that looks at satisfaction. I think it was quite hard to measure because across the 4 countries, the ways in which satisfaction are measured are different. One of the things that we also publish as the Nuffield Trust is our British Social Attitude Survey, so that doesn't include Northern Ireland, but it does look at satisfaction with social care over the last 40 years or so, is it? And it's been really quite stark how much social care has decreased in terms of satisfaction in recent years, and I think it's become much more of a political topic. Mark, I don't know if you want to add anything to that.
Fantastic. So, do you have any other question?
I do. Yeah. Oh, there you go. I do. I'm going to be really ambitious. I'm sorry. So, in terms of are we measuring the right thing or not? And I know it's really complex. I know the UK has done a lot of work on defining person-centered coordinated care through the National Voices Coalition. I'm not sure if that's the right term. Is that something you've considered, that maybe it could be a good measure, sort of like asking people to use that definition to rank or something?
Yeah, it very much was, and we looked for various patient experience measures. But unfortunately, as you say, while a lot of work has been done on that, it's relatively recent. And of course, we had a criteria of comparability across the countries, which really gets, you know, even the social care question we used, the wording was slightly different, but it was okay. But to compare in that way, you'd need quite consistent wording for what people were being asked in any sort of survey-based data. So it was a challenging one to measure. I think we certainly did find, when we looked at the literature for this project, some evidence that it might have been a good thing to measure, because there is a strong body of evidence that integrated care initiatives, at least on an operational level, can certainly improve that. But it wasn't necessarily as overwhelmingly prominent as you might think in policy literature at the time, and unfortunately we weren't really able to find a strong comparable metric for it.
Thank you. I know you have burning questions, but let me move to part B. But if you send these, your question through Q&A, I promise I'm going to take this, and the proof of that is that I want to read one question that has come through the Q&A, which says, I represent the municipality of Athens, welcome, which is about to start an IC project, integrated care project, with national funding. What is your advice regarding the key points we should focus on for designing and implementation? And this is exactly what we are going to do in part B. So I'm going to invite Joan Carles Contel from Catalonia. They've been in this journey towards integrated care. So they are going to reflect, and while he's going to speak, so just remember that last slide, because it's there. So the evidence is telling us what is missing, what's not missing, and then the question is, these guys who have been on this journey for a while, if they, what do you need if you need something? If you look back, like 10 years ago, 5 years ago, right?
Thank you. Well, Arturo, I think we have 10 minutes to explain about the history of our long journey. I think we are in the journey, we are in the middle, because we expect to have more time to achieve this kind of things. No? I think I want to explain the main features. We have structured our presentation in 3 parts. No? The first part, it is about how we started in this kind of journey. But first of all, I would like to explain about which is the situation in Catalonia. It's the main features about the situation in Catalonia. You could see here, we have 1 million inhabitants. We have own competences in health and social care. We have the possibility to organize, we have some kind of devolution with competence to organize the services in Catalonia, separate functions as in England, between the commissioning, purchasing from provision. The access to social care is means tested, and we have variable types of co-payment by the users. And we don't have, or it's not complete, aligned boundaries, the coterminus, of boundaries between health and social care services. In most of the cases, it's very similar, but it's not exactly the same. That is the situation we have in our country. But I want to start. When we have started with this journey, I think it was very important, the situation we had and we have in Catalonia. We have a very intensive process of aging in Catalonia. You could see in the middle of the century, we will have about 1/3 of the population over 65 and over 12% of the population over 80. Another important thing is when we have started 12 years ago, we tried to start with some kind of unique disease management, but we have changed very quickly into a new case management or care management orientation, especially for people with multimorbidity and people with complex needs. I think most of the cases you have people with heart failure, COPD. We have noticed most of these kind of people, they have different kind of chronic conditions, and we feel very comfortable with this kind of multimorbidity and complex care. Another important thing is we have introduced, within complex care, some kind of identification of the people with advanced chronic disease to introduce some kind of palliative care orientation. I think some kind of first transition of palliative care for this kind of population. I think it's very interesting because we have the possibility to seek and to register in the clinical record this condition of complex needs and the condition of advanced chronic disease. I think it was very important. Another important thing, it's not an advantage, it's on the contrary. We have 5 elections in 12 years. I think the time we dedicate to explain our narrative to the new politicians, I think it's very exhausting. And we have a new election in 2 weeks. I think it's very exhausting process to explain a lot of times the same. But on the contrary, we have a team of professionals, a stable team of professionals working at the Department of Health. We are called the assemblers. We are trying, it doesn't matter the politicians, I think it's very important to have an agenda of chronic and integrated care and to maintain this kind of agenda. Another important thing is if you have well-developed primary health care, I think it's very important because primary health care, especially for identifying and caring for people with multi-chronic conditions, I think it's a very important approach. And I think it's very important if you have a solid primary health care, you have a good advantage to work with this kind of populations. Another thing is we have noticed the importance to identify not only the clinical complexity, but also the social complexity. We have started little by little, but now at this moment we have some kind of operational way to identify this kind of social complexity. I think it's very interesting because when you are identifying people with health, both health and social care needs and complexity, I think it's very important to identify and to make proactive management with this kind of population. Another important thing is to involve on board the clinical and the professional leadership, and especially the clinical and professional leadership within primary health care. I think we are trying, the professionals working in primary health care, make good orientation to this kind of care management for this kind of populations. And we have introduced per every one case manager working in primary health care together with the primary health team for maybe 20,000 or maybe 30,000 inhabitants. Another thing is about the care pathways, especially for complex people. We have some kind of agreements at local level, at county level, with the hospital, intermediate care, and primary health care to make some kind of agreements what to do in case of crisis, what to do in case of transitional care, and we have local agreements about these kind of things. Another important thing, it is about the IT developments. From the very beginning, we have tried to identify these kind of people in the clinical record, because in Catalonia, we have a unique clinical record in primary healthcare. It's possible to identify and register the people who has complex needs, and I think it's possible to put. And you could see on the left some kind of customized viewer of the situation of the person with complex needs. You have all the utilization of services, hospital, emergency care, different kind of things, and the multidimensional assessment, the different kind of domains related to functional, cognitive, nutritional, and social assessment of these kind of people. When you have a complex people and you think this person is a complex people, I think it's possible to put this kind of viewer and all the professionals, including the people working in the emergency care, in the hospitals, could see this kind of picture. The same with the kind of algorithms. As we have a unique primary care record, I think it's possible to have all the information of primary care, and we are adding integrated information from hospital, intermediate care, and we have the possibility to have all the information aggregate, and we have some kind of homemade algorithm named GMEA, it's some kind of multi-morbidity grouper, and we have the possibility to make a national stratification of all the population of Catalonia and offer this information in the clinical record for every general practitioner and community news. The same with some kind of a strategy relating to make a consensus on the multidimensional joint assessment. And another important thing we have developed some months ago about to have some kind of frailty rapid assessment, related to make a rapid assessment, maybe in 8 minutes, related to the situation of the people with frailty. I think it's some kind of tools. We have developed and validated these kind of tools, and we have introduced these kind of tools within the clinical record to use by the clinicians in primary health care. Another important thing is related to the indicators. As we have all the information aggregated, we have a unique database from primary health care, hospital, intermediate care, mental health, and emergency care. It's possible to have population-based indicators related to utilization of services. For example, it's possible, if we have almost 400 primary health centers, it's possible to calculate the rate of emergency admissions, not only for all Catalonia, but also per every primary health center. And it's possible, this kind of information, to offer this information to the director of the primary health center. I think it's very interesting because we have indicators related to complexity, the people who is in home care, and the people who is in residential care. Different kind of things we are now. Where are we now? Yes, we have the agenda of vertical integration between secondary care and primary health care, but we are reinforcing this kind of integrated care with social care. We have an agenda now to create an agency of integrated care. This kind of agency of integrated care is not a third department. It's an instrument, to have instruments and tools to drive integrated care in terms of financing, in terms of, for example, governance or IT solutions, ICT solutions. And I think it has been approved by the government, and we are waiting for the approval of the Parliament. I think in the next session, in the next term, it will be approved by the government. And practical things. For example, you could see here when we are implementing integrated care in home care or integrated care in residential homes, we have some kind of checklist, and very practical checklist. When you are going to the territories, to the counties, I think you are checking the different key elements related to this kind of integrated care. Or for example, offering, not only having at national level these kind of indicators, but we are delivering and offering different these kind of indicators. For example, there are indicators related to residential care. I think it's possible to have these kind of indicators in a population base available for the managers and the commission and health authorities working at community level, at county level. Okay, 1 minute. Okay. A very interesting thing is the problem we have. We are trying to share information among health providers. I think it's easy. We have a national joint or shared electronic health record with all the information of health, but we have some problems to introduce and incorporate this kind of information from the social care services. We have legal barriers, we have some kind of cybersecurity concerns. And I think it's very difficult, and there are very few countries in Europe with this kind of agenda. I think it's very important to have this agenda for the next month. And the last thing, it is related to work in not only internal clinical leadership, but also to drive and push some kind of system leadership. I think here in UK, I think you have good examples of this kind of training. Okay, that is the last slide. Thank you very much.
Well, we put up the slides for the Basque Country. Can I, can I ask you very quickly, just for our colleague in Athens, seeing all these tools now operating, which is the only one that you think that has been the most important, that you think that has been the real lever that has, all of them are necessary, but which one is the key one? Just choose one. You have 20 seconds, or just one word.
So?
Yeah, just choose it. Choose it.
Maybe the most important thing is to involve the clinicians. For me, the most level of satisfaction is to have people and clinical leaders, professional leaders, who are trying to make the same narrative. I think to have this kind of impact in the leaders at county level, working in the same agenda and developing this kind of new narrative.
Fantastic. I think that summarizes that for our colleague in Athens, that's the key thing. Fantastic. Now, we've got somebody from the Basque Country, Gorzabala, and they had elections on Sunday. So again, remember, politics is important. So please, Igor, cuando quieras.
11 minutos. Okay. Hi, everyone. Good afternoon. I'm not depending on the politics, but anyway. I'm not a director. I'm just a head of a service. So I try to tell the things from my perspective. First of all, thank you, Arturo, for having me. I should say it's a bit difficult to answer questions you made us to how to evolve in the future and so on. But I'll just give my opinions, my reflections on this. I've been all these days reflecting on that. But the facts are one thing, and the reflection is another thing. So this is the Basque Country, very small population, to more than 2 million people in North Spain. We got a universal healthcare coverage, and we are now 13 integrated care organization, fully integrated organization. More than 300 primary care centers and more than 30,000 people working in the system. Just a preview, but particularly we are, just as the previous one mentioned, trying to manage particularly these patients from the upper level of the system, the high complex needs patients. We call them complex patients or multimorbid patients. So these are for us the big laboratory, in order to, whatever we do there, we may translate into the other system. So we got 75,000 people with multimorbid patients in the Basque Health Service. But from them, we just covered 25,000 people into the clinical pathway. You'll see a bit later what it means. So when we talk about integrated care, I have no data on this, but when we talk integrated care, this is our view of what integrated care means for us. What we did was change regulation, and at that time, the Basque Health Service. After a while, we saw some things that didn't work, so we worked more on pushing the primary level. we stratified the whole population in the Basque Country from the high needs for the ordinary people with no health needs. And we try to work on what is care or clinical pathways, because we see that this is the way where integrated care is fully deployed through this consensus between professionals. And if you ask our professional for them what integrated care is or means, probably most of them they will say that integrated care is a unified clinical record, because all those systems, primary and hospital level, they share all information about the patient they share, and as well they can talk to each other, professionals from both systems. And non-face-to-face strategy as well. New roles, particularly in the nursing area. Social and community are now big feature, big actors in this particular movie. They were before, and not such as they are now. The other one is citizen empowerment, which is one of the big areas we're trying to evolve and give them strength. And during these days, and particularly this morning, I was talking about how to collaborate, mainly professionals from the different levels. We call it innovation from the professionals. So where professionals have ideas and let them to carry out with those ideas. And of course, how do you finance those processes, and how do you evaluate what you are done in this time? And the last one, I would say, and sometimes we in Basque Country, we sort of create new structures. Like you see, this one, my department is one of them. Try to push and foster wherever integrated care means. And the other one is now Biosistema Kroniune, which is a foundation in order to research on, in this case, in care organizational issues in the Basque Country. So, this is our journey. Very, very quickly. This is the last picture. So, we began in 2009. This is 13 years of story. Well, this is a history. Well, I tell you my story on this process as well. We began with a tackle of chronicity at the time, 2009. In 2013, we saw that the best way to answer the chronicity challenge at that time was to go through integrated care. And in our setting, we solved the problem, let's say, integrated care, by two sides. One is structural integration, and the other one was clinical integration. In that road, the right side is clinical integration, and the left side is about structural integration. So in 2013, we got a plan about how to integrate our organizations, primary settings and hospital setting, into just one organization, just one board. And in 2015, all our organizations were fully integrated. What you saw in the first slide, 13 ICOs, integrated care organization. In 2018, we came up with a new, let's say, law how to manage this organization. New directorate for this new ICO organization was created. And in 2019, we went with some evaluation, let's say, how our assessment on this project was. And we saw at that time some suns and clouds, lights and darkness. So we discovered that probably in order to go further with integrated care, we should go through some changes, particularly in the primary setting. We need to work quite more in primary setting to foster the primary setting. So we stopped at that time. And in 2021, we decided to create a new, let's say, directorate in the headquarters, in the upper level of the board system in the Basque Health Service, which is the Primary Care Directorate. And in 2024, we're working for a new strategy for this primary care setting. On the other side of the picture, this is more clinical integration, not just the structural integration. And we were with this patient I mentioned before, the 25,000 people with multimorbid patients, high complex needs, and so on and so forth. So, it's okay, I finished. So we went that clinical pathways with a big consensus from professionals from both health level, and we saw at that time that we got better outcomes than previous years. So we scale it up to the whole system, but again, in 2019, we went into an evaluation process, talking with professionals and managers, and we saw that things were improving, but not as much as they're supposed to be. So again, we revisited the clinical pathway again with professionals and front professionals and managers, and we made some changes in the process in order to go on. So all the time is revisiting, renewing, changing. This is very important, with a lot of talking with professionals and managers as well. So some reflections in order to how would you go on further in this process? I would say these 7 reflections, but the last, I think, probably to me is the best one. And some of the speakers in the previous roundtable mentioned it. Keep faith and be patient. This is a very long way. This is not happening from one day to another, but it's important, as Rafael Bengoa mentioned the first day yesterday in the morning, strength strategy at policy levels. This is key in order to transform the system from upper level. But the narrative should be very easy to understand, very easy. Otherwise, it's quite complex to carry on with it. A clear alignment among all actors to focus very well the issue. Double-side leadership from top level, but also from the bottom level, from the professional level. And planify the change management. Planify. This is not happen because of this. It needs to be planified. There is some successes and some setbacks, and that's not bad. It does not happen everywhere. So go on with that. And as well, during these sessions, is one again and again, listening to patients should be part of the process. So it's some part in this movie, and sometimes it's not. In our case, I think we should be working quite hard on that. And the other one is the last one. Keep faith. Thank you. Thank you.
Fantastic. I'm going to invite Shelley now to explain about Wales and the Welsh journey, and just to say, yeah, you need to be a believer, right? Keep faith and be patient. But thank you very much. I think this is very helpful for those of us who might be in the process. So, Shelley, sorry. Yes, you introduce yourself.
Thank you. Good afternoon, everybody. And I'm sure you're all coming towards the end of a long day and really keen to get off to the gala dinner or wherever you're going for your dinner tonight. So hopefully we can give you some really helpful insights just to finish your day off. Oh, that's not my slide. How do I get my slides up? Here we go. So I work in Welsh Government. I was just sitting here reflecting now, thinking, gosh, I joined Welsh Government in 2018, but actually I've been working in the health and social care partnership landscape for over 20 years. So the point about being patient and committed and tenacious about what you have to do, that long-term view definitely chimes with me, because it takes a long time to make the changes that you want to make, and we've still only moved about that far along the system. A little bit about Wales. So we're a small country, and we've got a population of 3.1 million people. We have 22 local authorities that run our social care system, and we have 7 health boards that offer our health system. And actually having that volume of different organisations in a country so small creates variation, because everybody wants to do things their own way. One of the narratives we often hear is it's different here, but there is a question about how different can things really be in such a small space. We have a global budget of health and social care of about the 9 billion. That's the figure we kind of think when we look at all the collective resources we've got together. But we do have dedicated resources we put specifically into the integration space. So we have the £146 million of the Regional Integration Fund, and we have over £70 million that goes into capital build around developing integrated hubs. And all of that is managed through our regional partnership boards, which I'll come on to. So I was thinking about how best to present the journey we've been on, and I think it's felt like we're trying to build a jigsaw, but we've actually not had a picture of what's on the box, what is the thing we're trying to build. So we had all these ideas, thoughts, ambitions put in front of us, and then it's been a case of, so how do we now build that? And it's interesting, you know, I think if you had your time again and you started to apply a proper change methodology to something in a clear plan, you might start in a different place. But we started where we started, and this is the journey we've been on. So we started off with legislation. We set the mandate nationally. We had the the Social Services and Wellbeing Act, which set out the ambition around integration for health and social care to work together through regional partnership boards. And at the same time, we had another piece of legislation that came out in a similar space, talking about the well-being of future generations. And those two pieces of legislation really did complement each other, but there was overlap. Both created a set of partnership arrangements. So we had 7 regional partnership boards, and we had 19 public service boards that sat under the Wellbeing Future Generations Act. And we did have some tension in the system about who was looking at what, which partnership was meant to be looking at which bits of the jigsaw. And I think over time we have worked through that, and actually the system started to align itself. So we're starting to see public service boards that are on those local authority footprints starting to amalgamate of their own accord to fit with the footprints of the regional partnership boards. We've got closer relationships. So that was the mandate. We then looked at creating the structures, as I said, through the partnership boards. And then we started to look at, well, what are the systems, what are the services, how do we actually make that integration happen? And that's where we put resources into the system. So we had the Integrated Care Fund at the time, and that has now evolved into the Regional Integration Fund. But we also had a strategy in a Healthier Wales, which is a 10-year plan for developing our health and care system for the future, and there was a heavy focus on integration, and we also launched a capital fund. But in none of that did we articulate and say, and this is what it will look like, this is what you're trying to build, this is what good integration is. So we've worked through those enablers that we've got, and tested from a top-down and a bottom-up approach. So we've had the mandate from government and the structures to help us do it, but the resources at a grassroots level to test, innovate, look at ways to integrate services and bring the two together. We've had review points, and we had a first review in 2019 when we reviewed the legislation. I'm picking up the point from the Nuffield Trust about pooled budgets. In our original legislation, we said you must pool budgets for commissioning older people's care homes. And we found through various reviews it wasn't happening, that partners weren't moving with that. So in our review in 2019, we tightened that up and pushed that even further and said these must be regional pooled budgets, these footprints, you need to do this. And we still found that people weren't doing it properly. A lot of effort went into describing a process that looked like a pooled fund that really wasn't a pooled fund. So our latest review, which we did a white paper in 2021-22 and a programme of change last year with lots of engagement. we started to review some of those mechanisms. For pool budgets, we've actually decided what we needed to do was more clearly position pool budgets within the context of what they were meant to do, what they're meant to achieve. So it's about actually how we design and commission services jointly together, which pool budgets may or may not be a tool to use. So we've offered some greater flexibility now for partnerships within that, in the hope that it will make more sense to them. We also asked the question about, should our regional partnership boards become a corporate legal entity in their own right? So similar to Scotland and England, where their partnership arrangements are that corporate legal identity, they can hold their own resources. We asked the question in Wales, and the response back was, no, don't do that. We think that the current arrangements are strong enough, but we just need to tighten them up to help us deliver what we want. And there's various things we've done in there to really look at the scope, clarify what it is we want regional partnership boards to do. And that's the journey we've been on there, really refining what we've already got. These are some of the messages that we've persistently had along the way, and they're really contradictory in nature at times. So we've got people saying, well, what do you mean by integration? What does good look like? What's the vision? What are you trying to achieve here? Tell us what you want it to look like. Against, well, actually, we know best locally. Don't overprescribe it. Don't tell us what to do. Our community is different and we need to do something. So there's something, a real tension there, but how do you balance that national down mandate and leadership with that flexibility for things to look local? And I think going forward, that's what we've really tried to build into our next phases. A little bit about our structure. So we don't have an integrated health and social care system at the top, and actually our current direction of travel is almost going to reinforce that separation. So we've recently launched an NHS executive to help drive improvement in our health services, and we have a programme of work to develop a national care service for Wales. So at the top, we're not on a trajectory to connect these things together structurally. So that means that the integration, the interface has to happen through our partnerships at that regional level. So we have the 7 regional partnership boards. But underneath that now, we are now bringing primary care into the equation. It was a gap previously, we weren't connecting with them. And we've brought primary care in so that we're connecting with the local cluster arrangements. We have 60 of them in Wales to make sure that our local to regional to national thread runs both ways, and we can get that local place-based delivery within a national context. Our RPBs have the usual people you'd expect around the table, so health, social care, and it's they that have the duty to cooperate on them. The legal duties sit on the health boards and local authorities, not the partnership. The partnership's not a legal entity in its own right. So that, I think there's pluses and minuses to that, but actually what it does do is it doesn't create the partnership as a separate thing that's responsible for integration. Actually, the health boards and local authorities themselves are responsible for this duty to cooperate and drive integration. And we also do make sure that we've got carers, citizen voices, provider voices around the table, and we've just done a programme of work to really strengthen that, because we found that carers and citizens were telling us we're struggling to get our voices heard. It's really hard in a room full of professionals to actually communicate, so making sure people are properly supported to engage with the system. And we've also done some work to really define what do we mean by integration. So if we're in a system that's not properly integrated at the top, to what extent can we really expect true integration? So we've started to recognise that this is more of a continuum, and actually there is sometimes having things that are aligned or joined up for our communities is good enough. It doesn't necessarily have to be a fully integrated approach. So that's been the other learning that we've had to try and express this more of a pathway. And then from all of that, we've really started to, I'm answering one of the questions earlier about what really makes the difference. Actually, having now narrowed our scope, being really clear, we are talking about integration in the community. So it's health and social care, third sector working together in the community. And we've created this blueprint now. So this is the blueprint that we've got, which sets our key system enablers, our models of care we want to develop, and the key population groups for whom we really want to look at active health management and positioning that within a locality place-based approach. I'm going to whiz through now because I've had my warning. So I think this is where we've got to. We've got our jigsaw now. We have got the edges and the corners there. We need to fill the middle, and that's the next drive. So the picture in the box is now going to be this blueprint, and our next programme of work is going to be really about making sure that we are taking the learning from what's best and escalating that up to scale it to a national level. That's not without challenges, because people don't want to change what they've already got. And then a big piece of work looking at people and culture and leadership. So on one of my earlier slides, we talked about systems, structures, and people. I think the people bit is the bit that we haven't focused in on enough. So really trying to make sure we're getting in to get that culture that is going to help us further drive this change and really embed it in. Okay.
Fantastic. Thank you very much. So it's great, well, it's great, no, but it's, I think, very reassuring to see that Wales, they've been on this journey for 10 years, and they've got the pieces, and they are building the puzzle. So they're still building the puzzle, and things they all said that. So now we need to move quickly as collectively. So we've sent you, it's actually me, from my phone. So if you check your Q&A for this session, go to your app, and then if the guys, you can put up that one. Yes, okay. But I think we need the previous slide, the one that we, no, with the link. Yeah, so it's, so you might find me in the Q&A for this session. I've said you can join our interactive voting exercise at menti.com. So you go to menti.com, you open your browser, menti.com, and enter the code 4127648. Shall I repeat? Yeah. Is everybody in menti.com already? Yes? Oh, fantastic. So 41227648, right? And what this app is going to allow us to do is to vote, and then we continue the conversation from there, because what we've done is that first question, which is how confident are you in these approaches to overcoming barriers to integration? So we'll start with the barriers then. We've selected these from the research. We've heard that how you've overcome those barriers, but you are struggling with those barriers, so you've introduced tools to overcome that. And so I want guys, if you start voting, and yeah.
Yeah, I think it's quite interesting how, so we've added a few as our experts were talking, and particularly I think hearing from Juan Carlos on the importance of data interoperability, which seems to be doing quite well. Well, things are moving quite a lot, actually. I don't know if the panel perhaps have some thoughts on some of the things that really make the most difference, but I think it's also interesting, I think we've had throughout the conference really the theme about the importance of co-producing approaches and bringing in people's perspectives and voice, the voice of carers, the voice of people who draw on care, the voice of patients, and I think that seems to be doing as well as one of those things that is really driving.
I think it's interesting that, as we highlighted in our presentation, the generation of UK, integration initiatives that we looked at put a lot of weight on shared budgets and shared governance structures, and they're maybe not doing so well up there, and that might reflect that perhaps people are developing an interest in steps closer to the front line rather than those more abstract structural things that are meant to bring them about.
That one will? Yeah. I mean, what's really interesting, there's not a lot between them all, is there? There's no sort of huge polarisation. I think that's because they're all really important. And that's the learning I've been on. We've started in one place in Wales, but actually we're having to plug the gaps now of the things we neglected early on. And really you have to pay attention to all of these things if you're trying to develop an integrated system. I think the shared budget's probably, for me, is the lowest, and yet that's one of the places we started. And all the advice that we had from our delivery partners was you started in the wrong place with some of that, particularly the subject matter that we attach those pool budgets to. I think for pool budgets to work, or shared resources to work, they have to be set within a purpose. Why is that going to make a difference? And I think if you're able to do that, then people will come on that journey. But at times it's been really difficult to articulate what is the benefit. We do have really good examples of shared budgets in things like community equipment stores, so where health and social care partners absolutely will invest together to make sure they've got the equipment out there in the community, and they will do that. But then in other places where it's much greater risk, it's harder to persuade them to do that sharing of resources.
Yeah, I mentioned in the presentation that in the Basque Country, the health record, the system information is absolutely key. They work, for them, this is the integration, the clinical record system information. And the other one is the professional leadership as well. We've seen in this long journey is that something that coming from the structural level or sometimes even a policy level, if professionals are not engaged by themselves in all these changes, probably you make a lot of efforts and or budgeting on something, but the professionals and the leadership is absolutely important in order to shift a bit the system. But don't forget as well all professionals are important, but as well the first one, let's say co-creation or collaboration with all social agents as well is absolutely important in order to, it's not just health system, not just about working together, hospital and primary level. It's about that, but it's quite more complex than that.
Two things about the most important barriers, about interoperability. I think it's very important to think about this kind of issue. I think it's very important, for example, in the case of Spain, in most of the regions, we have a unique primary healthcare record. I think it's very important because you have a very good basis where you could integrate different kind of layers of information. I think, for example, in Catalonia, we have 80% of the primary healthcare related to a unique system, but we have progress from 80% till 100%. I think it's very important because it's a very good example to have a good basis of information not to exchange and to share between different kind of providers. Another important thing is to exchange information between health and social care. I have mentioned before. In the case of social care, the level of maturity of the records, of the electronic records, I think it's very different. I think in the case of electronic social care records, in most of the cases, people are working or professionals are working with paper. I think you should introduce this kind of electronic social care record and also to standardize and harmonize the social care problems. For example, in the case of the health problems, we are using ICD-10, for example. You have some kind of international codification of health problems. But in the case of the social care problems, we don't have any kind of international codification of social care problems. I think there is a lot of work to make to structurate and harmonize this kind of information and after to make interoperability between the systems.
I would like to add, this is not in the screen, but I would like to mention how important is where the consensus between professionals trying to work with patients and manage patients, particularly in chronic diseases. And it's not on the screen, but I would say that all about care pathways and clinical pathways is as well absolutely key, because it's the place where professionals put all the efforts in order to manage patients and diseases, particularly chronic diseases.
Is there any question? Anybody wants to join? Are you happy with this picture? I think we've stopped now voting at 35, yeah? Next one, hopefully it's going to be quicker. So, yeah. Take that microphone, fantastic. Because we are going to do a second question, so we can close this one.
A few of you have mentioned that providers and professionals are important in integrated care and change. I'm just wondering how they've been included in the journey, because I'm a provider and I don't I do, but my colleagues don't speak the language of integrated care, of administration, of healthcare planning, right? So how do you explain integration and what you're trying to do in the system to the frontline provider who actually is doing something totally different in the clinical world and is not really, it's not resonating to them what integrated care means?
I think that's a really interesting question. It has been really difficult. One of the more recent analogies I've been using for the work we're doing in partnerships is that actually they need to be viewed as an iceberg. So the small number of people we have around the table are not it. They are just the representatives, and all the organisations, the communities they represent have to be brought on this journey with us. And that is one of the next phase we're really looking at. How do we make sure that we do that? We do have provider representatives around the regional partnership board table, so they have seats as well. We've recently just added primary care providers to that because it was a gap, and the Wales Ambulance Service Trust as well has been added. But we also have third sector and private sector representatives and housing social landlords. So they are represented, but they've got their own challenges in connecting that back. I'm hoping now we've got a clearer vision. It's clear what we're hoping to build, what the parameters are in that community space. It's going to be easier for us to communicate that and take them with us. I think one of the advantages we have got in Wales, though, because of our size compared to perhaps some of the other UK nations, we are closer to the people we serve, the communities and the organisations we work with. So I can remember a meeting not long back. I went with the minister who met with the UK Social Care Providers Forum, to which the English providers were kind of said, we're really envious of our Welsh colleagues because you've got that close relationship. You're regularly in dialogue with your decision makers, your ministers, in a way that they aren't able to do over the border. So there is something about small being beautiful sometimes.
That's a good question and difficult answer, probably. You have to communicate or let them know what is integrated care and what it is for, and how to involve those people in some, let's say, decisions and managing system and so on. In the Basque system, we in this integrated care, we got some act or some normative in order to be the professionals have the representation on those decisions in the integrated care organizations. And as well, there's a commission where the population and the council are involved in some decisions in the geographical area. If you are asking me, does it work in some sites or another? That's another question. Probably not as well as it should be, but we're trying to make it more dynamic in order to get more answers. And the other one is how do you promote to be the citizen, the neighborhoods involved in all these actions and to know what it's about. There's another challenge, and probably for next year, maybe we come with an answer.
Let me move to the next question because I can see that people are voting. We've got here 29 and then 77 responses. Oh, right. So we've got a okay. So this is the second question. You are already voting. Shall we give like 5 seconds so people stop voting because then it keeps moving and we don't know. Yeah. Yeah, shall we stop there? Fantastic. So guys, do you want to react to what you are seeing, which is the results from this voting?
Yeah, and I think it really echoes what some of the panel have been discussing about kind of creating. I think there's some interesting ones about shared perspective, shared purpose, and really driven, I think, by person-centered approaches, by better patient experiences, by better people experiences, and aligned with that as well, efficiency and quality. And I think it really feels to me like from some of the discussion that we've been having today, it's really important to make sure that those are the driving factors, the driving shared ambitions that are happening, and being realistic from a policy level about what we can do at a national level, if anything, to make sure that at a local level, these sort of ambitions, these aims are reflected and shared across all different professions that are involved.
maybe my reflection related to this kind of answers. I think I feel very comfortable with the idea of triple aim or quadruple aim or maybe quintuple aim. No? I think we have different kind of versions. I think you have some kind of balance, no? Between efficiency, person-centered care. I think it's very important to introduce some kind of measures. We are talking about the PREMS, no? The patient or person-reported experience outcomes, but we have very few measures related to this kind of things. I think it's very important to introduce this kind of measure related to this kind of dimension. Another, it is about quality of care and maybe equity and maybe the quality of the satisfaction of the professionals working with integrated care. I think that maybe the correct answer is the balance between the different kind of dimensions you should assess in integrated care.
Yeah, of course.
There are many manager or people from managerial areas here in the room. Efficiency at the end of the day is how costs are involved in the process. But you know this, not this particular event here in Belfast, but the previous before, we always talking about person-centered care and whatever. But as I see here, it's not the first one. Even that we could some add in some other expression, but efficiency is quite in the front line. I would be surprised. Maybe I'm quite romantic, and I thought that it would be more person-centered care anyway.
I totally agree. I have to say personally that I'm very, I'm not going to say disappointed, but to see efficiency so centrally, it has. But that's absolutely fine. That's how we feel integrated care is. Any other reflections, Shirley?
Yeah, just the last one from me. It's really interesting that, when you think about how you connect people to this agenda, integration is hard work, it's a change. People are going to ask themselves, what's in it for me? Why am I going to put time and effort into this? So I think to articulate the change that's needed to take people with you, you have to satisfy that for them. So what will it mean for service users? What's in it for you? What will it mean for operational services and delivery staff? And what will it mean for your organisation? And you've kind of got all of them covered off there, So it's just really interesting that those aims are spread across all of those three domains. So you've got better outcomes for people, which is what the individual wants. Being able to work in a person-centered way, that's what we know our workforce wants to be able to do. And efficiency, that's absolutely what our organisations want so that they can manage the challenging resources situation that they've got.
We've got 1 minute. Yeah, yeah, actually that's interesting. So more than a question, would anybody close down the session with a reflection? More, not really a question, but a reflection on this. Yeah, okay, happy to. Not always here the panels have to close the sessions. I think it's going to be nice that we've done it collectively, so please, go ahead.
I won't close it, but the reflection is you're disappointed on efficiency. And one slide before in the execution strategies.
You come closer to
sorry. In the execution strategies, one thing I think was missing is the integrated business case. So what's the win-win of the different parties involved? And I think this is one of the key challenges we have to figure out in practice. So how does this look like? How does it work? Because it won't change overnight without neglecting efficiency. It's important in practice, and it should be addressed also in the execution strategies. At least that's my perspective.
Fantastic. Thank you very much. We are on a journey. That's what we are learning. Yes, we are at this moment. We see this. We have to juggle with all the elements, and we've got a lot of tools. We've seen these 3 countries, a lot of tools. Next time Nuffield Trust does another study, hopefully we're going to get better results. So thank you very much to everybody for being here until 6 o'clock. And please, if you join me in a round of applause to the whole panelists. Thank you.